Okay, turn to page 3, chapter 1. I've got 10 rules of a successful eye clinic. These rules, I suggest you try to follow them. I know it's human nature to go off on tangents, but I think if you stay with this, you'll be a lot better off. Number 1 is don't reinvent the wheel. Learn from my mistakes and trial and error discoveries. Number 2 is keep it simple and be as self-contained as possible. Simple and self-contained. If it can malfunction, it probably will. Instruments are way too complicated. Carry essentials with you all the time and carry duplicates if you can. And assume one trunk will be lost or late. Number 3 is good attitude and flexibility are essential. Expect plans to change, taxes to be late, etc. Just be thankful for whatever you accomplish. You cannot use the same criteria for success in a third world country as you do here, because they just don't do things the same way. Just smile and try to connect with every patient. Aim for 90% accuracy, not 100% accuracy. Under ideal conditions, refraction is an art and not a science. We don't deal with astigmatism, and I'll talk about that later. I prescribe here what I think the patient will accept, not what the patient needs. If the patient needs a big change in prescription, I don't dare give him what he needs, because if I do, we'll have the most feared condition any eye doctor ever sees. It's called the bent wrist syndrome. And what that means, the patient will come back in and say, "Doctor, I just can't wear these glasses. They make me sick, and they gave me a headache." And so basically, patients in this country are not willing to go through the adaptation period. So you give them what you think they'll accept, not what they really need. But with children, you give them what they need because they'll adapt to it. So we treat adults like children and children like adults. Number 5, speed is essential spiritually, medically, and economically. Spiritually, because you want to get as many patients as possible in to see the counselor. Medically, because you want to treat as many patients as possible. And economically, because you want to minimize your cost per patient. If you have a trip that costs $3,200 and there's 49 hours of clinic time, then if you see 20 patients per hour, 3 minutes per patient, you'll see 980 patients. If you see 6 patients per hour, which is 10 minutes per patient, you'll only see 294 patients. So your cost, if you see 980 patients, is $3.27 per patient. If you see 294 patients, your cost is $10.89 per patient. Thus, your speed greatly affects your cost per patient. Number 6, a good interpreter is critical and can make your job at least 80% easier. Try to keep the same interpreter throughout the entire trip, and we'll cover how to train the interpreter later. Number 7 is good news, bad news. A is good news. You'll be able to help about 95% of the patients with glasses or eye medications. You'll do more good medically in one clinic than I do in North Carolina in months. On a medical mission trip, there's a very good chance that if you don't provide the care to the patient will just go without care. Whereas in North Carolina, there's plenty of eye doctors. If I never see another patient, nobody will go without care. B is the bad news. You'll have the heartbreaking experience of not being able to help about 5% of the patients with corneal scarring, advanced cataract, glaucoma, retina or optic nerve problems, etc. Some of these patients you could help in America. Some of these patients you couldn't even help here. Number 8 is good crowd control is critical. In some countries, you'll have to close the clinic if you lose crowd control. You want to keep about 3 patients close by to get the next patient in the chair as quickly as possible. The rest must be kept back in a designated area. You must avoid something I call creeping chaos, in which the patients will inch closer and closer, and you'll have 3, then 10, then 20, then 50, and then you'll be out of business. So somebody has to be the bad cop and enforce the arbitrary rules that you set up. Number 9 is don't get frustrated or upset. If you're in a hot, dirty, dusty, uncomfortable environment, remember this is the environment your patients live in all the time. Again, just be thankful for whatever you accomplish. Number 10, the spiritual benefits to the patient will be incalculable. Christians will be encouraged, and between 10 and 35% of the non-Christians will pray to receive Christ. The ones that do not accept will be reminded of the counseling by the glasses for several years. And so you'll just do a tremendous amount of good on a trip, I promise you. Okay, then we're going to go into chapter 2, which is basic optics and refractive conditions. Okay, basically the thing that you need to always keep in mind is that there's an optical entity called a prism. And a prism is an optical device with a thick base that comes to a point focus. And you need to always remember that a prism bends light toward its base. We work with two types of lenses, plus lenses and minus lenses. A plus lens is two prisms base to base. Since the prism is in the center, a plus lens will converge light to a point focus. A minus lens is two prisms apex to apex. Since the base is on the outside, a minus lens will diverge light. So a plus lens converges light and a minus lens diverges light. Okay?
I think we got every.
All glasses do is move focal lengths around. You're trying to, the assumption is that the eye is healthy. If the eye is healthy, then the light has to focus on the retina. If it does not focus on the retina, then the vision is blurry. So all glasses do is just move focal lengths around to get the light to move from wherever it is to the retina. Okay? Now we deal with nearsightedness or myopia and hyperopia and farsightedness and presbyopia. Those are the three things we deal with, and we'll talk about all at great length later. So hyperopia, myopia, and presbyopia. Okay? Now myopia is a problem in which the eye is too strong. It bends the light too much, and so the light comes to a point focus inside the eye. And what happens to light once it comes to a point focus? It starts diverging, right? So by the time the light rays get back to the retina, you have a blur circle on the retina. And the visual cortex cannot handle a blur circle. And so therefore the vision is blurry. So this patient is myopic. If the patient is hyperopic, then he has the opposite problem. The eye does not bend the light enough, and so the light tends to focus behind the retina. So if it focuses behind the retina, what do you have on the retina? A blur circle. And the visual cortex can't handle a blur circle, and so therefore the vision is fuzzy. Now what did I say the one thing glasses do? Move focal lengths around. So all we're trying to do with glasses is move the focal length from wherever it is to the retina. So if, I am nearsighted. So when I take my glasses off and look at something far away, it's fuzzy. I can't see it. And the reason it's fuzzy is because my eye is too strong. The light, when I look at a distant object, the light focuses inside my eye. And when the light gets back to my retina, I have a blur circle, and the visual cortex can't handle a blur circle, so my vision is blurry. So what can we do to push the focal point from inside the eye back to the retina? Why don't we put a minus lens in front of the eye? And what does a minus lens do? Diverges light, right? So if we put the appropriate power minus lens in front of my eye, when the light rays, rather than being parallel, when they hit that minus lens, they're diverged. And if I have the appropriate power minus lens that I look through, and the light rays are diverged the appropriate amount, that's going to push the focal length back to the retina and have a point focus on the retina, and my eye is healthy, so therefore, with the appropriate powered minus lens, I can see clearly far away. So all glasses do is move focal lengths around. In my case, since I'm myopic, I'm moving the focal length from inside the eye back to the retina. Okay? Now, the reason that you can see clearly out a window is that both sides of the glass, the surface is parallel, it's not curved. So therefore, when you're looking outside at something, the light rays coming from that object pass directly through the window without being bent and come into your eye. So a flat surface does not bend light, a curved surface does bend light, okay? And so we use curved surfaces, plus and minus lenses, to put the focal point on the retina. Now, if a patient is farsighted, the situation is a little more complicated. And the reason it's more complicated is, in my case, it's very straightforward. There's nothing my eye can do to push that focal point from inside the eye back to the retina. I have to have a minus lens right here to do it. And what does the minus lens do? Diverges the rays and pushes the focal point from inside the eye back to the retina, okay? A person that's farsighted, things get a little more complicated, and the reason it's more complicated is that God put an adjustable plus lens inside our eye. And that is why, have y'all ever wondered why a young person can see clearly far away and see clearly up close? That's absolutely phenomenal, but nobody really thinks about it. The reason they can do that is that right behind the pupil of the eye, there's a little organ called a crystalline lens. And this is essentially a God-given adjustable plus lens that a young person can use. When a young person looks at something far away, the light rays are coming in parallel, the lens inside the eye is flat, and the light rays focus on the retina. Now, when that young person looks down at a book and the light rays are diverging, the light rays should focus way back here, but they don't, because as soon as the brain realizes that the young person is looking at a book, it sends a message to a little muscle inside the eye called a ciliary muscle. The ciliary muscle tightens up and tugs on the lens, and the lens becomes an artificial plus lens. And what does a plus lens do? Converges light. So therefore, the light rays that are diverging from the book go into the eye, hit that plus lens, and they're converged enough to focus on the retina. When the young person glances up at the clock on the wall, the muscle relaxes, the lens flattens out, the plus lens goes away, and the light rays are parallel, and he can see the clock on the wall. But the problem is, as we get older, some chemical changes occur in the lens so that it starts losing its elasticity. And this is a condition called presbyopia. So typically, around age 40, the lens hardens enough and loses elasticity enough that you start pushing things farther away to see it. And so then what do we do? What can we do to help a person that's presbyopic? Their God-given plus lens is not working anymore. So why don't we give them a plus lens and a pair of reading glasses? And that's essentially what we do. So a plus lens corrects presbyopia. So, and what we're doing again is just replacing the God-given plus lens that's not working anymore with an artificial plus lens and a pair of glasses. Okay? Well over half the patients you see on a mission trip, you'll be dealing with problems with the lens inside the eye. And it's real important to understand the life cycle of the human lens. In a young person, the lens is clear, so the light can go right through it, and it's very flexible. So therefore, a young person can read, and he can see clearly far away. When that young person hits about age 45, some chemical changes occur in the lens so that it's not as flexible as it used to be. Then the 45-year-old has trouble reading, and we call that presbyopia. And essentially, the lens inside the eye is hardening. And so they need a pair of plus lenses to replace the God-given plus lens that's not working anymore. So presbyopia is, you'll see lots and lots of patients with presbyopia. Then when this 45-year-old hits about age 65 or so, some different chemical changes occur in the eye, and the lens starts getting hazy. And when it starts getting hazy, then we say the patient has a cataract. So presbyopia and cataracts will be the most common things that you'll see on a mission trip. Okay? So y'all can read about the anterior segment. Down at the bottom, the cornea is the clear dome-shaped window at the front of the eye. And the big deal is it provides 85% of the light-bending focusing power of the eye. So the cornea, the curvature of the cornea is critical to getting light to focus on the back of the eye. So any ideas how a surgeon can correct nearsightedness? With a surgical procedure? Reshape the cornea, exactly. And what's that procedure called? LASIK. LASIK. And so remember, what's the problem with a nearsighted person? The light's focusing where? Inside the eye. So what do we need to do what do we need to do to help them see better? Move the focal point back to the retina. We can do that with a minus lens, right? We can also do it by flattening the cornea. So LASIK surgery just involves making an incision, taking the outer layer of the cornea, folding it out of the way, letting the laser vaporize part of the middle layer of the cornea to flatten it and put the outer layer back in place. So you're doing exactly the same thing, just a different method with the LASIK procedure. The cornea is clear, and it is the only tissue in the body that does not get oxygen from red blood cells. Every other cell in your body gets oxygen from red blood cells. But it really wouldn't work very well for us to be looking through a bunch of blood vessels. So the cornea gets this oxygen supply from tears on the outside and a fluid called aqueous on the inside. But if somebody abuses their contact lens and the body decides the cornea is not getting enough oxygen, it'll start growing blood vessels into the cornea. So it supply oxygen the old-fashioned way with blood vessels. So whenever we see blood vessels in the cornea, we know that the patient's probably abusing their contacts. The cornea is made up of 5 layers, but for our purposes is made up of 2 layers. The outer layer and the middle layer. And the big deal is the outer layer heals back clear, the middle layer scars. So the epithelium, if you have a corneal abrasion, you're probably just taking away some of the epithelial cells. And if you keep from getting infected, it'll heal back clear, and you'll never know it was there a week later. But if it gets infected and the corneal ulcer eats down into the stroma, when it heals back white. And so you have a corneal scar. So the name of the game is to keep everything confined to the epithelial layer. So on page 17, it talks about the 5 layers of the cornea, which y'all can read about if you're interested, but not really relevant to a mission trip. Just, the thing to remember is you want to keep everything limited to the epithelial layer. So y'all can read about that if you're interested. Page 18, same thing. The anterior chamber, there's a fluid produced inside the eye called aqueous. And if the plumbing system gets clogged up, or if the eye produces too much aqueous, then the pressure inside the eye goes up and the patient has an eye disease called glaucoma. And glaucoma is an eye disease that we used to think we understand. Now we know we don't understand it. The more we learn, the less we know we know. We used to think it was a simple plumbing problem where we could just open up the plumbing and that would solve it, but it's not nearly that simple. This was really brought home to me 2 years ago. We had a new eye doctor move into town, and I had lunch with him. And he said, David, we don't understand glaucoma very well. I said, this is great. You just finished a 2-year glaucoma residency at Duke University Eye Center, and you say you don't understand glaucoma very well? If you don't understand it, I don't think anybody does. But anyway, that's not something we deal with on a mission trip, so it's not really relevant for our purposes. Okay, page 20 is the posterior segment, which is basically everything behind the lens, and this is totally irrelevant as far as our purposes are concerned. So you can read about the vitreous, which is a thick jelly-like fluid that fills up the back 2/3 of the eye. You can read about that if you're interested. The retina, the visual cortex, is just a vastly complicated subject that you could spend a long, long time on that we're not going to mess with. But just remember, the retina, the visual cortex has to do a lot of adjusting. If it didn't do its adjustment, we'd all see double and upside down. So it flips it over and puts it together for us. The retina is the inner layer of the back of the eye, and this is where all the nerve endings. The optic nerve is like a big cable full of copper wires, and each wire goes inside the eye and then goes out and is located. The end of the optic nerve is at a certain point on the retina, and that's how we localize ourselves in space. If something from over there stimulates my temporal retina, then my brain knows that that object is on this side. So that's how we figure out where we are. by which optic nerves are stimulated. The bottom of page 21, the choroid is the middle layer of the cornea. It's the blood supply layer. The inner layer is the retina. The choroid is the blood supply. Then the sclera is the white of the eye. And again, page 22, the optic nerve. It's just all the optic nerves come together there and go in a cable back to the visual cortex in the brain. Page 23, the conjunctiva. That is a big deal. Get out your eye doc in a box photos. You know, conjunctivitis or an inflammation of the conjunctiva is a common infection that y'all will see. And in the middle row of pictures, the left side is what a normal conjunctiva looks like. As you can see, it's kind of a healthy pink color. Once you see a few normal conjunctivas, you'll know when one is abnormal. Then the middle picture shows you what an infected conjunctiva looks like. The body sends blood to the area to try to fight the infection, so the blood vessels dilate. And so the conjunctiva swells and the eye gets real red and angry looking. So when you see that, then you're probably dealing with a conjunctivitis or an inflammation of the conjunctiva. Okay, look on page 24, pathology. There are many ocular diseases that cannot be treated on a medical mission trip due to lack of instruments, facilities, or the chronic nature of the disease. Thankfully, only about 5% of the patients you see will have these conditions. Most of these conditions involve the posterior segment behind the lens, involving the retina or optic nerve. An example of a chronic condition that requires daily eye drops for the rest of the patient's life is glaucoma. As I said, we really don't understand glaucoma very well. The goal of glaucoma treatment is for the patient to die before they go blind. You're trying to keep useful vision through their entire life. You can't really cure glaucoma, you can just control it. By far the most common and frustrating conditions you'll see real frequently is cataracts. There are tens of millions of patients in third world countries that are blind due to cataracts. In some countries, there are government programs to provide cataract surgery at reduced cost. In India, they have a Lions Club government program where you can get the surgery essentially free. And for $21, you can get the patient to the hospital, get them their eye drops, get them food in the hospital, and everything. So remember on the video, I had the patient counting fingers. If I can get them counting fingers with glasses, then I just give them glasses. If I cannot get them counting fingers, then I send them for cataract surgery. This year in India, I identified 81 patients that I could not get seeing well enough to count fingers. So we made arrangements for them to get cataract surgery. In other countries like Mozambique, it's just not available. Cataract surgery is available in the capital city only. The rest of the country has no cataract surgery, which is just really incredible. So when the patient sits in the examination chair, you do a quick eye evaluation with a pen light, pull the inferior lid down and evaluate the conjunctiva, look for redness, swelling, and discharge. If the chief complaint is redness and discharge, ask about itching and the color of the discharge. If there's redness with yellow or green discharge, it's probably bacterial conjunctivitis. Treat it with an antibiotic drop if you have it. If the discharge is white associated with itching, it's probably allergic conjunctivitis. So give them artificial tears or Benadryl or an antihistamine. Page 25, look for pterygium, pinguecula, and subconjunctival hemorrhages. Look back at your color pictures. Remember what a pterygium is? It's a growth that starts on the white of the eye and moves out across the cornea. Pterygiums are not real common in this country. They're much more common in South America. We don't really know what causes pterygium. The theory is that being outdoors and the chronic irritation causes it, but we don't really know that. The thing to remember about pterygium is that you want to have the pterygium removed when it gets about 2/3 of the way across the cornea. So if this is the pupil of the eye and this is the cornea, the pterygium starts on the white of the eye and starts coming in, and it carries its blood vessels with it, as you can see. So if you see blood vessels in the cornea, you're probably dealing with the pterygium.
and it grows very slowly. And when it gets about 2/3 of the way across the colored part of the eye, you want to remove it. And the reason you want to remove it then is because when a pterygium is removed, if you look at a cross section of a cornea, if you got a pterygium here, right at the leading edge of the pterygium, they have to go down deep into the cornea. And when they go down deep into the cornea, what do they get into? The stroma. And what happens when you mess with the stroma? Scars, right. So they go down deep and then come back up and peel it off. So you're going to have a scar right at the leading edge of the cornea. And you want that scar to be in front of the iris. You don't want the scar out here in front of the pupil, because if so, it'll adversely affect their vision. I was in Peru a few years ago, and this guy sat down and had a huge pterygium. And I asked my interpreter to tell him, you know, you've got an eye problem called a pterygium, and you need surgery pretty soon, or it's going to really affect your vision. He looked at her and said, I make like $2.25 a day, and I have 3 kids. I can't afford to feed my family. How am I ever going to get eye surgery? What do you say to that? I don't know.
Is that a fast-growing?
No, very slow. They move extreme. We watch them for years and years here. You can watch a pterygium for 20 years. They don't move very fast at all, thankfully. Okay. Pinguecula. Anybody remember what a pinguecula is?
Nothing to worry about?
Nothing to worry about. It's some sort of growth on the white of the eye. Anything on the white of the eye, on the sclera, is called a pinguecula, and you can pretty safely say it's nothing to worry about. And then the subconjunctival hemorrhage, what is that?
A scar.
Not a scar. A blood, accumulated blood under the conjunctiva, and on top of